Can everybody hear me? Is that okay? Doesn't sound too fuzzy. Thank you all for coming out today. Really appreciate it, and really appreciate from Paul and everybody at John Muir the opportunity to speak. It's a real privilege to talk to you guys about something that I have a real passion and interest in, as I hope you'll see, and it's the surgical treatment of chronic headaches. A couple of disclosures to start off. I'm a consultant for Axogen, which makes a cadaveric nerve allograft, as well as Pacira Pharmaceuticals makes a long-acting local anesthetic, and these two consultancy relationships have absolutely no bearing on anything that I'm going to discuss here today. The outline of the talk, we're going to talk about the scope of the problem, which really never ceases to amaze me in terms of its magnitude. What the current treatments are, very briefly, for chronic headaches, such as migraines, and what this whole peripheral nerve concept is with regard to this disease pathology, what the results, obviously, of surgical intervention are, how we select which patients we operate on, and what it is exactly that we do, and a couple final thoughts, which hopefully will sort of circle back and complete the picture. As I said, every time I give these talks, and I've given this a number of times at some of our international and national meetings, as well as in forums like this, as well as various patient groups, I'm always just struck by the degree of this problem. In the U.S., there are over 36 million people been diagnosed with migraines. That's nearly 12%, and that's just one headache subtype. It doesn't include some of the other more common types of headaches. So it's about as common as breast cancer, which sadly is a very prevalent problem. The female to male preponderance is 3 to 1. And the estimated costs in terms of direct costs, hospitalizations, medications, visits to the ER are in the tens of billions of dollars per year. That data, as you can see, is about 10 years old, and so those numbers have only certainly increased in that time period. And this translates to basically yearly expenditure per patient in terms of just direct costs of over $7,000 a year. If you add on top of that the indirect costs of days off of work, expenses for child care because of an inability to care for a child or a loved one, again, in 1999, so these numbers have only increased. 100 million days of bed rest have been attributed to chronic headaches. It's certainly a significant economic cost, which adds an additional $12 billion to our yearly expenditure for the U.S. healthcare system. And that adds an additional yearly expenditure of $4,000 per patient. This, of course, does not take into account a lot of the other emotional psychological sequelae of chronic pain, such as chronic headaches. And in this really interesting study by Turner Bowker and her colleagues, she was able to demonstrate in over 7,500 patients that the health-related quality of life of somebody suffering from chronic migraines, in this case, approached that or was equivalent to that of somebody suffering from congestive heart failure and diabetes. So clearly a debilitating problem. The prevailing concepts with regard to chronic headaches, such as migraines, are, in a nutshell, that the problem is something wrong within the central nervous system. There's a lot of different sorts of theories: the cerebrovascular instability, cortical spreading depression, problems with the trigeminal vascular system, and this first and third one have actually been sort of coalesced into one unified hypothesis, most recently, I think, by Peter Goadsby in a lovingly comprehensive 70-page review article in February of this year. There are certain cytokines that are thought to be dysregulated, such as serotonin, and most recently calcitonin gene-related peptide, as well as substance P, and more esoteric potential etiologic factors, such as a patent foramen ovale with microemboli. As you might expect, the mainstay of therapy, if you suspect some kind of chemical dysregulation in the central nervous system, has been pharmacologic management. You can see we have not only many different kinds of drugs that are used to treat chronic headaches, but many different classes of drugs that are used to treat these problems. I'm not going to read this list off to you, but they start with the antidepressants, go all the way down, including the CGRP receptor antagonists that just went into, I believe it's phase 2 clinical trials in Europe. In addition to pharmacologic management, there's a lot of non-operative modalities that are done as adjunctive therapies. These include physical therapy and acupuncture, all the way down to biofeedback, hypnotherapy, and various kinds of injections, including epidural steroid injections, facet joint blocks, trigger point injections, and of course, therapeutic Botox injections according to the preempt protocol. Now, stepping aside a little bit, a different concept came to the forefront almost 20 years ago, and it's what I call the peripheral concept, obviously because it involves the peripheral nervous system. And it's kind of a funny story as to how this came about. There's a fairly famous aesthetic plastic surgeon by the name of Bauman Guyron's written a number of textbooks as well as numerous book chapters and articles on various aesthetic procedures. And one of the aesthetic procedures he does quite often is an endoscopic brow lift. During this operation, you make several incisions behind the hairline, dissect down under the skin and above all muscle and above the cranium. And looking with a camera and working with a long instrument, you're able to resect some of the glabellar musculature, as well as often resect the zygomaticotemporal branch of the trigeminal nerve, or just zygomaticotemporal nerve for short, to facilitate elevation of the brow. What he realized as he operated on a number of these patients is that a number of them, a small subset, would come back and say, "Doc, I love how I look, but I used to have these horrible headaches, and they're either significantly better or gone." And when he went back and retrospectively looked at a bunch of his patients over a certain period of time, 4 years in this case, he found 39 such patients that had headaches before, and of those 39 patients, 31 were saying they had significant or complete relief of their headaches post-surgery. So this prompted him to do a prospective pilot study where, going forward, he started to ask all of his patients who were having surgery, "Do you have headaches?" He would treat them with Botox as a diagnostic maneuver with the presumption, and these again are all frontal headaches, that you have compression of the supraorbital or supratrochlear nerves and the glabellar musculature. If you had a positive result with Botox, usually about a month or so of relief and improvement in frequency, severity, or duration, he then went on to operate on these people and resected the corrugator supercilii muscle to decompress the supraorbital and supratrochlear nerve, and in some cases, depending on the distribution of their symptoms, to resect the zygomaticotemporal nerve as well. And 21 out of 22 of these patients reported a successful outcome, again, which we define now as at least a 50% or more reduction in frequency, severity, or duration. And yet about a year follow-up of these patients. An interesting observation from this small study is that a number of these patients, especially those that still had some persistent symptoms, because as I said, success is defined as about at least a 50% improvement in frequency, severity, or duration. Many of those patients said that they had residual headaches in other areas of the body, specifically temporal, and other areas of the head and neck, specifically temporal or occipital, and this prompted him to do a series of cadaver studies which demonstrated that there were other potential compression points in these various areas. So eventually, and this was published again back in 2005, so it's over a decade old now, he did a prospective randomized trial where he followed 125 patients. 100 of them were randomized prospectively to have to be offered surgery, and if they responded to Botox, which in this case 89 of them did, they ultimately underwent surgical interventions. Now we're talking about decompression at various points, including frontal, temporal, as well as occipital. And they followed 25 controls, patients who were randomized to the control group, and were followed with the board-certified neurologist who has been a co-author on just about every single one of these studies, including the ones mentioned to date, using International Headache Society criteria for chronic headaches. These patients were followed for a year with standardized questionnaires such as the MIDAS, short form 36, MSQ, etc. And what they found was in the surgical group, a year post-op, 35% of the patients were reporting complete elimination of their headaches, and an additional 57% were a minimum of 50% improved in terms of those three parameters we talked about earlier. In the control group, only 16% of patients reported some improvement in their symptoms, and no patients reported complete relief of their headaches. This type of work has been repeated by others in other centers and in other areas. Yvonne Duchik, who was running Georgetown's Peripheral Nerve Surgery Center at the time this was published, did 190 patients focusing on the occipital area this time, and a year after surgery, 43% of patients had complete elimination of their occipital headaches, and about an additional 40, for a total success rate of 81%, had that minimum 50% improvement. And then, remarkably, this next study is really interesting. Bauman Guyron, again at Case Western Reserve, somehow got this by the IRB, but had a placebo-controlled, prospective, single-blinded surgical trial. So in this study, he had 49 patients randomized to actually have the surgery, and 26 patients actually randomized to have sham surgery. No idea how this passed the IRB, but I think we're all glad that it did. These patients were in the surgical group, obviously had the typical decompression of whichever nerves we were talking about, and in the sham surgical group, they made the incisions, they exposed the nerves, and then just left them compressed, as it were, and I guess watched TV for an hour and a half or so, and then ultimately just closed the incision. Again, using standardized metrics to follow the patient's improvement or worsening, if you will, post-op. And 1 year after surgery, 57% of the patients in the actual surgical group were reporting complete relief of their headaches. Only one patient, 4%, was reporting a similar level of relief in the sham surgery group. An interesting finding was that 84% of the patients in the actual surgical group reported the minimum 50% relief. So we're looking at 84% success rate. But 58% of the patients in the sham surgical group also demonstrated a significant improvement in their headaches. So there is certainly a placebo effect here, or perhaps something that we're doing in our approach to these nerves without the actual decompression that is a component of the relief patients experience post-op. But these two numbers, 84 and 58, were actually statistically significantly different. So we still think actually operating and decompressing these nerves has a lot of benefit. He continued to follow these patients, and the 5-year results were published in February of 2011. In this case, 79 patients were able to be followed for that long. Again, all the usual same metrics. 29% of patients were still reporting complete elimination of their headaches, and 88% were still reporting that significant improvement. So an 88% success rate at 5 years. And these type of data have been repeated in a number of different centers by a number of different clinicians. Lisa Frere and Jay Austin at the MGH in that top study, again, 90% success rate using the migraine headache index at a year. Joe Poggi in Kansas, very similar numbers, and I presented 100 patients of mine several years ago at the California Society meeting. A 2-year follow-up, again, about a 90% success rate in terms of frequency, severity, and or duration according to the migraine headache index with a 40% complete relief rate. So all of these data together start to bring us to what I call a potentially new concept that may be at play, not necessarily in isolation, but perhaps in combination with central issues. And I call this the peripheral concept because obviously it has to do with the peripheral nervous system. And in this case, we're talking about peripheral nerves that are pinched or irritated in the head and neck region, specifically in the frontal area, the supraorbital, supratrochlear. In the temporal regions, zygomaticotemporal, auriculotemporal, and the occipital, you've got greater, lesser, and third or least occipital nerves. And the nasal trigger site, which we'll touch on briefly, is because it's a little different in cases of people who have Schluter's neuralgia, contact point neuralgia, or concha bullosa. And the idea here is if you have these nerves that are pinched or irritated, they will send messages back to your brain, much like if you step on a tap with your big toe, and those nerve endings will tell you that you're having pain, and if the pain's coming from the head and neck area, you're going to call that a headache. So who's a candidate for these types of operations? There's 3 main criteria that I would use, and I think most of the other clinicians that you'll see mentioned in these various citations would agree. You have to have a good history for a pinched or irritated peripheral nerve in the head and neck causing your headaches. What does that mean? Well, all the patients need to have at some point been evaluated by a headache specialist or board-certified neurologist, make sure we don't have any other ongoing neurological abnormalities that have not been addressed. Surgery is never, ever, ever the first option. Okay, I'd be the first one to tell you that. So these patients have to have failed pharmacotherapy, and not with 1 or 2 drugs, usually with a number of different drugs from a number of different classes of medications. And unfortunately, that's not too difficult to find. They have to have failed a lot of non-operative modalities, physical therapy, acupuncture, massage, all those ones we saw earlier. I often insist on negative imaging studies, so at some point they've had an MRI of the brain. Ideally, a CT scan, if it's totally negative, is a good screening tool. We don't have an aneurysm, we don't have a brain tumor, we're not dealing with multiple sclerosis or any other organic brain pathology that we can see, and specifically for any patients that have occipital headaches, negative imaging of the cervical spine. I want to make sure we don't have foraminal stenosis and an impinged nerve root or a fractured vertebrae that we've missed. And usually patients have to have significant impairment. Now, any severe headache can be argued as a significant impairment, but usually the people that I see in my office are not having 6 to 7 migraine days per month. We're talking 15, 20, 25 headache days or more per month. And a lot of these patients, when you drill down and talk to them, will tell you, look, I'm never without pain. I usually live at a 2, 3, 4 if I'm lucky, and what I'm calling my migraines is when the volume on that same baseline discomfort gets turned way up. What are some of the things that people will present with if they have peripheral nerve irritation or compression causing their symptoms? Well, in the occipital area, you're going to have occipital or cervical, upper cervical pain, tightness, pressure. These are typically worse with stress, exercise, heavy lifting. A lot of these patients, again, if you talk to them, will have some element of history of whiplash, even though they've had all the negative studies. In the temporal area, they usually have, obviously, temporal pain, but usually significantly tender points, again, over the zygomaticotemporal and auriculotemporal nerves. A lot of them have a history of clenching or grinding their teeth and have been diagnosed at some point with TMJ disorders. They usually wake up with their pain, although none of these are 100% pathognomonic. In the frontal area, you usually have a suprabrow or supraorbital discomfort, usually, again, worse with stress. Like people have dynamic frown lines even in repose. They have a lot of wrinkling and very large glabellar musculature, especially prominent in females when it usually is more prominent in males. A lot of them will have brow and lid ptosis when their headaches flare. In the rhinogenic area, they're usually sensitive to weather changes, allergies. They get temporary relief with decongestants, and I'll show you why that might be in the next few findings. And unlike the other areas, a lot of these patients will have CT or imaging findings that will potentially clue you in that this is a problem, whereas in the other areas we've mentioned here, the imaging studies are usually read as negative because even with MR neurograms, these nerves are too small, in my opinion, to be adequately imaged in terms of abnormalities when you're comparing, for example, a nerve root emanating from the spinal cord to the sciatic nerve, which are much larger and much more easily imaged with current technology. So in addition to a good history for a pinched or irritated peripheral nerve in the head and neck causing your symptoms, you have to have a good physical exam. And I often try to see my patients, and I tell my patients, look, I want you to come to the office in as bad a state as you can possibly muster and still walk into my office. And during these exams and during these flares, you can often find positive Tinel signs, much like you can if you percuss gently over the carpal tunnel. I submit to you, if you palpate or percuss gently in the correct areas, you'll be able to find radiating paresthesias in the appropriate areas. They'll have positive trigger points. They really should have no restriction of their head movements or neck, so we want to make sure we're not ruling out other types of cervicogenic or musculoskeletal issues, and that's also a technical consideration depending on which area you're talking about in terms of positioning in the operating room that will impact your ability to perform successful decompression or, in some cases, neurectomy and muscle implantation. As we said earlier, it should have no ongoing active neurologic abnormalities. And in terms of psychiatric abnormalities, obviously a lot of these patients have a reactive depression. This type of chronic pain, as I said, is often very debilitating. So that is no longer an absolute contraindication. But patients, and when it comes to any sort of pain, numbness, or tingling, they have to be able to relate what it is that they're feeling to you in terms of pain as well as relief potentially of pain. So if you have someone that has severe mental retardation, if someone is floridly psychotic, these would be contraindications because it would be hard to gauge whether or not they're having any significant improvement or worsening of their symptoms because they can't relate to you in a consistent way what might be going on. And finally, the third criteria is you have to have a good response with, in this case, nerve blocks. We used to use focal Botox injections. This is different than the preempt protocol where you get the 31 injections, 155 units, and the various modifications thereof. There's a lot of reasons. If we have time, I'm happy to go over why we don't use Botox anymore, but one of the main reasons is the compression points are not necessarily all muscular, and so Botox will give you a false negative if you have a non-muscular compression point, because the Botox will not be effective in that case. In addition, Botox, as many of you may know, takes several days to become effective, whereas if someone can come in at a 9 out of 10 pain and you can use nerve blocks sequentially blocking one nerve after another, you can't do them all at the same time. You're often going to know within 15-20 minutes which nerve or nerves are having a significant impact on that pain, and therefore which nerve or nerves you may want to operate on. So what is it that we actually do during these operations? And I'm glad everybody's sort of finished eating, so hopefully this doesn't gross anybody out. But in the occipital area, as I said, the three main targets, the greater, lesser, and third occipital nerves. If you make a posterior midline incision, as we've done here, and reflect the trapezius, which you can't see here because it's been moved laterally with these hooks, you see the vertical fibers of the semispinalis here, and you see a bulge in greater occipital nerve right there. If you remove a little piece of this muscle, and the size of the muscle may look large here, but if you look at the size of the hair, you can see we're actually magnified quite a bit. This is about a thumbnail size piece of muscle, and a muscle that extends beyond the borders of this image. So it's effectively a muscle biopsy because these nerves really aren't that large. But what I would call your attention to is the fact that despite if you look at the hair here versus the hair here, on the right, the image is more magnified, and I think that the nerve here looks actually a lot smaller than it does here, which is a decompression procedure, something you see quite a lot. If you were to take a rubber band and tie it off the base of your finger would swell with blood and become engorged. When you release that, the blood goes away and your finger resumes its normal appearance. You see that often when you do these types of decompression procedures, and then there are other areas. We continue deeply here to the obliquus capitis, and here more caudally, cephalically and laterally to remove any branches that might be compressing into the occipital artery. And then you often take a little bit of a subcutaneous muscle flap and move that back in here to fill this space so that as this muscle continues to contract in the future, that nerve will be pushed against a soft cushion, if you will. Now, the types of compression topography for the greater occipital nerve, which has 6 potential compression points, have been worked out in a bunch of studies, including this really nice one from Jeff Janis, where you have compression at as the nerve comes around the obliquus capitis right here, as it goes to the deep and superficial layers or fascia of the semispinalis muscle, as it goes to the superficial and deep layers of the trapezius muscle, which has been cut out here for illustrative purposes. And as this nerve comes in close proximity with the occipital artery, sometimes you have a single cross type of architecture that you can see here, and sometimes the nerve is completely wrapped like an anaconda by the occipital artery, which with every pulsation will squeeze and irritate that nerve. And we look at all of these in every patient. The lesser occipital nerve is another area and a particular interest of mine. Here's a patient that's lying prone on the operating room table. She's actually had a facelift by a very prominent aesthetic plastic surgeon in San Francisco. And one of the things that you do with a facelift is you elevate this entire skin heading to the neck and then pull back. That can lead to a lot of scar tissue that can form on the inside, which would be a normal reaction to that type of procedure. But it can also ensnare various nerves. And here, you'll have to trust me on just this one picture. There's the posterior border of the sternocleidomastoid. This little white structure you see here is the beginnings of the lesser occipital nerve, and all of this other white, thick fibrous stuff is scar tissue. When you release all that, you can see the nerve now has a lot more room to move. You can see the posterior border of the sternocleidomastoid a lot better. You have nice, soft fat here, through which the nerve is passing in a small tunnel. But most importantly, again, you see a nice yellow nerve here that corresponds to the area that was not compressed before, whereas a lot of the scar tissue more cephalically was removed. You now have this hyperemic swollen nerve, and this is classic in terms of what you find intraoperatively when you take a nerve that's compressed at one point and remove it. And I was able to publish my work on the compression topography, if you will, of the lesser occipital nerve. Last year, we have 3 compression zones and various branching patterns. As you can see, for example, in this patient, the same incision, patient's prone, here's their ear. This is the lesser occipital nerve, posterior border of the SCM, but you can see the nerve has already branched. And if you look caudally, so if we take an image of that, you can see that there's actually 2 little foramina, one here and one here, through which these various branches are going to pass, and there's this thick fibrous septum. If you wanted to, you can actually pick the patient's head off the table just by holding onto that. It's really thick, very tough tissue. If you remove that septum, you now have a lot more space for the nerves to glide. So as you turn your neck backwards, rotate it left or right, flex it or extend it, those nerves are no longer pinched with movement. In the temporal area, the triggers, the targets are the zygomaticotemporal branch of the trigeminal nerve, or just zygomaticotemporal nerve for short, and the auriculotemporal nerve. In the case of the zygomaticotemporal nerve in the anterior temple, the compression is usually a sentinel vein, very large vein, that runs along right next to this, and as it passes through the temporalis, the superficial temporalis fascia, which is known as the deep temporal fascia, you get compression of that nerve. And at the auriculotemporal nerve, again, like with the greater occipital nerve at compression point 6, you have often an intimate relationship with the superficial temporal artery, which can cause a compression. The initial descriptions by Ali Tatanchi and his colleagues, a good friend of mine and a great surgeon, was to use, again, an endoscopic approach. You make the incisions behind the hairline, dissect down in what I think is a relatively large dissection plane underneath the skin to access the zygomaticotemporal nerve. And usually, because you're working with longer instruments endoscopically and you don't have any tactile sensation, the only option was to perform a neurectomy and implant that nerve in the temporalis muscle. As a person who does about 200 or operates on 200, 250 nerves a year, I always found that a little unsatisfying because I always want to feel what the nerve is like. It should feel like a soft, wet noodle. If it feels like a banjo string, there's a lot of scar internally and an internal neurolysis, or a neurectomy has to be performed. And I like to try and manipulate these things with my hands to be able to do a decompression and neuroplasty as opposed to simply having the option of just resecting a nerve out of hand. This is the image that you typically see when you do an endoscopic approach. Again, we're looking through the camera from the vertex of the skull anteriorly, and you can see the temporalis muscle here at the base, the skin and subcutaneous fat up top here, and here's the zygomaticotemporal branch of the trigeminal nerve or zygomaticotemporal nerve emanating through a very tight fascial covering. The sentinel vein here has already been cauterized, so you can see it better. And my thought was always, well, can't we do a little bit better? And I actually published, again, last year, a simplified approach using a modified Gillies incision, which is an incision any plastic surgery resident can tell you about, which we use to reduce zygomatic arch fractures. We modified the approach a little bit, and so on this drawing, you have the patient facing this way into the screen, so that is their eyebrow, and this is their temple. Make an incision behind the hairline, dissect anteriorly a centimeter or two. You can find the sentinel vein fairly easily, and once you cauterize that vein, because it's a redundant vessel, you can see the zygomaticotemporal nerve again fairly easily, and it's hard to see because the nerve really is that small, and I'm a terrible photographer trying to shoot in a hole. In this case, you have a preserved fascicular pattern, intact vasa nervorum. The nerve feels nice and soft, which you can feel with your hand, so this nerve is able to be preserved. You still have the option of performing a neurectomy and muscle implantation. We can also just open up a little fascial window, take a little bit of fat from the temporal area and pad the nerve, and Bob's your uncle, so to speak. If you retract posteriorly, as we often do because patients who have temporal headaches that are caused by peripheral nerve problems also have often issues with the auriculotemporal nerve. If you retract from that same incision posteriorly, you can often find, it doesn't image that well, but the superficial temporal artery here right next to the auriculotemporal nerve, and you can treat that nerve in the same way. This is a patient 3 years post-op of mine, and you can see it's a very acceptable aesthetic result, usually with a hidden scar behind the anterior hairline here. An interesting thing that is related to the temporal nerve, zygomaticotemporal nerve specifically, again, Baumann Geiron was able to take a number of these patients in whom he was doing an endoscopic brow lift where this nerve is resected almost routinely, and sent these nerves off for electron microscopy and proteomic analysis, and compared the same analyses in patients who have headaches and in whom he was resecting the zygomaticotemporal nerve as well. And when you look at the difference, the patients who are headache patients were routinely demonstrating a disrupted myelin sheath, abnormalities in neurofilament organization leading to certain axonal abnormalities, which we think are a component of, or perhaps a result of, the pathology which is causing a lot of their symptoms. In the frontal area, typically, again, the two targets are the supratrochlear nerve here and the supraorbital nerve, which is drawn as having two, a medial and lateral branch. I would draw your attention to the fact that the supraorbital artery here is drawn well away from the supraorbital nerve, and that this nerve comes out through a nice supraorbital notch, as it's supposed to do. But Rob Hagen, who's a good colleague and friend of mine, has elegantly showed in a series of cadaver dissections, as well as a clinical series of patients, that notch is often an actual bony foramen. And so this is here's the upper lid. This is the actual bony foramen through which you see a lot of stuff. And if you actually do a little ostectomy here, you can actually expose the supraorbital nerve, which has now been effectively decompressed. And you have a little blush of a vessel back here, which is the supraorbital artery that has been cauterized back and is now no longer pulsating against this nerve and hitting it against a fixed space. And so people often ask, is this a placebo effect? Certainly, like with any study, it's possible that there is some placebo effect, but there's clearly anatomic compression of these nerves, and you can see it all the time. And I have videos I can show you occipital arteries compressing the greater occipital nerve, etc. Briefly, to touch on the endonasal trigger, it's a bit of a different animal. In this case, as I said, imaging studies are often very helpful. In this case, you can see patients often have a deviated septum, and the idea here is that the mucosa that lines not only the septal portion of the nose, but also the lateral portions of the nose, including the turbinates, is extremely richly innervated. So when you have something like this with an enlarged turbinate called concha bullosa, often you can get rubbing from side to side and irritation, these headaches. You have sometimes actual contact points, which has been called, the nomenclature is a little controversial, Sluder's neuralgia. And in this case, the procedure is, again, a little different. Usually it's some combination of a septoplasty, turbinate reduction, or turbinectomy, and as opposed to resection or decompression of a specific nerve. The socioeconomic impact of these types of operations is actually also pretty profound. Faber, a few years ago, followed 125, I believe, patients for over 5 years. And the migraine medication expense alone, per annum per patient, was decreased by $2,000 a year. Patients on average were missing 8.5 fewer days of work per year. Median cost reduction annually was over $3,900 per year, and there were significant improvements in the migraine disability assessment questionnaire and their quality of life metrics as well. So clearly an important improvement. What are the possible complications for these types of operations? Well, in addition to the fact that in some cases, if you have pancranial neuralgia, that's really thought to be compression of multiple nerves in multiple different areas, sometimes you have to stage the operations. There are a few practitioners out there, and this is really just a matter of opinion among the few of us that discuss this often and do these operations. Some people will operate on all 3 or 4 zones in one operation. I personally think that's quite a bit to recover from. So sometimes you have to stage the procedure, and you'll have your occipital surgery on one day, wait 3 to 6 months minimum to see if you have any improvement, and if you have residual symptoms that are bad enough in these other areas, they can also be addressed. In addition to that type of issue, you can have scalp itching, minor alopecia, incisional cellulitis, seroma, and even brown movement, obviously, if you're resecting more glabellar musculature on one side than another. Neck stiffness, obviously, if you're working the occipital area. But fortunately, the incidence of complications is relatively low. And in the case of, for example, neck stiffness can often be ameliorated not only with tincture of time, but massage and physical therapies. You can work a lot of the scar out. So just to leave you with a couple of final thoughts, I probably talked too long anyway, but basically chronic headaches are obviously a significant problem in the United States as well as worldwide. I would say that not all patients have central nervous system problems. Some people certainly do have a peripheral nerve peripheral nerve problem. And if all other modalities have failed, I think that surgical intervention is safe and effective. I would add a couple of other final thoughts here. I never mean to suggest, I don't think anybody of any worthwhile reputation would suggest that this is how you treat headaches nowadays. That would be an absurd statement. However, I do think it's a very powerful arrow in the quiver of modalities that we have to offer some of these patients, especially when they failed all the more traditional kinds of therapies. And I think personally that ultimately chronic pain is going to be best treated with a multimodality approach. So much like breast cancer, where you have the surgical component, you have hormonal therapy, chemotherapy, radiation therapy, mind-body medicine, nutritional supplementation, and so forth. All that put together gives you the great remission rates and success rates we've had with breast cancer. I think chronic pain is going to be the same kind of thing. A multimodality approach is ultimately going to be the best, because while we do have a nice subset, about 30% or so of our patients that have complete relief of their headaches, that means most of the patients still have some headaches. And one of the refrains that I hear most often is, doc, before surgery, I have 25 migraine days a month, and I had Imitrex, the only thing that ever worked, but geez, it only worked 50% of the time. I could never figure out, I took it early, I took it late, I took it in the middle of an attack. Sometimes it worked, sometimes it didn't. Now after surgery, the frequency and obviously duration, as we'll talk about in a second, has significantly decreased because every time I take the Imitrex and I'm only reaching for it 6 times a month instead of 26 times a month, yes, that's better. When the headaches are bad, they're bad, and I need the Imitrex. But gosh, it almost always works. I don't understand it. What's different? And I think what's different is that you actually have a chemical abnormality, which is appropriately treated by medication. That's really where the medication is going to be most effective. And in many of these patients, you actually have a mechanical compression on some or a number of different, sometimes a single nerve. So preoperatively, you don't know what's causing your headache. You take the medicine, and sometimes it works if it's the chemical issue that's at play that day. If you have a mechanical compression causing irritation, it's ineffective. Post-surgically, you've removed that second stimulus, and so now you have a headache. It's the chemical abnormality. More likely than not, you take your medicine, and it's actually more effective. And I think you put all these things together, and we're going to, I think, really hopefully make some impact on a lot of these patients. So that's all I have today. I'm certainly happy to answer any questions for you, but thanks for coming out and thanks for listening.